Hi, good morning. My name's Brian Huntley. I'm a professor of hematology at the University of Cambridge, and I am a clinician who looks after patients with AML, and I also run a research laboratory with an interest in acute myeloid leukemia. So I've been asked about mutational patterns. What are they, and do they affect outcomes of patients with acute myeloid leukemia? So start with a little bit of an introduction about the genetics of acute myeloid leukemia. So like all cancers, acute myeloid leukemia is associated with the acquisition of mutations in patients' cells, in this case, in their blood cells. And the combinations of these mutations lead to the development of leukemia. In particular, they cause a block in what we call differentiation. That is where the cells mature into the mature cells in the blood that carry oxygen, that cause the blood to clot, and that fight infection. And these mutations also drive a process called proliferation, which is just where the cells remake themselves. And that's why acute myeloid leukemia is associated with a lack of production of normal blood cells and failure of the bone marrow, and also with an increase in these primitive cells that we call blasts. So we've known about these processes for a number of years, 50 or more years, and we have been able to look at them with varying degrees of sensitivity over that time period. That's really been enabled by new technologies. So we've known that the chromosomes, that's the large units of genetics, have been abnormal, and we've been able to look at these and count them for a number of years. That's a process called cytogenetics. The genetics are related to the number of chromosomes that a patient has, and chromosomes are the large unit of selection in a patient's DNA complement. We now have an idea that there are mutations that occur at the level of single genes as well. And that's really been enabled by a massive leap in our technology and ability to sequence DNA, which has occurred over the last 10 to 15 years. Nowadays, as you've probably heard, we can sequence the whole genome. That's every gene and every base pair within the human DNA template, and we can come up with mutations that have been acquired and that drive leukemias. Now we're using this extra level of sophistication to look at mutations, specific mutations in genes that are associated with varying degrees of good or bad behavior. And that is becoming common practice. In the UK, every patient with acute leukemia is having their whole genome sequenced through Genomics England, and this takes quite a while to get back and is not so helpful for clinicians. So at each hospital, they're putting together what we call panels. That's much more specific, smaller numbers of genes that we know have what we call prognostic. That is the ability to predict outcome. And we do these and try and turn them around as quickly as possible. And these can be used immediately for treatment decisions. For example, patients with an abnormality of the FLT3 gene, that's a signaling molecule, will be treated with inhibitors of FLT3 and as close to the beginning of their therapy as is possible. So we now have a good idea of the mutations that occur. And the next stage in the process is to try and put together what they do to the disease and how they might help us to treat patients. Now, they can help in a number of ways. They can help to predict which patients will do well or badly to existing therapies. They can predict those patients who would benefit from a bone marrow transplant. They can also predict for those patients who do not need a bone marrow transplant, because as many of you will know, that's a very toxic therapy, and it is something that we don't use without a great deal of consideration. But the other thing that they can do is they can predict how patients will perform when treated with some of the new agents that we are getting available to us. And all of the new clinical trials have these sort of genetic assessments. And one of the main things that we want to do is to try and select those patients that will do well. And if patients have a mutation where they won't do well with these drugs, then we can think about moving them to a different and more novel experimental therapy. So the complexity there is that there are not tens of mutations that occur in acute myeloid leukemia. There are actually hundreds that occur, and there are sort of 20 or 30 that occur at a reasonable frequency. There are between 3 and 5 mutations that occur in every case of acute myeloid leukemia. So you can begin to see it starts to become quite complex, and we need large numbers of patients to work out the prognostic ability, the ability of the presence or absence of these mutations to tell us how a patient with AML will behave. So acute myeloid leukemia is not a common disease. Around about 3,500 patients have this disease per year in the UK. And what is happening is that we are pulling together with our collaborators on the continent, in North America, and all around the world to give us an idea of which mutations will predict for what outcomes and how they will behave when they're treated with these new novel agents. So that's a very large and sort of interdisciplinary organization, but it's the only way really to get the information that we need in as short a time frame as possible. If it was left to single countries to do that, this would take decades, and that's just too long because we still do not do so well with patients with acute myeloid leukemia. So in answer to the question, that's what mutational patterns are, and that is the main reason that they can affect outcome in patients with acute myeloid leukemia.